My purpose is to teach you all with the help of this video that how can we integrate things together. Like how can we integrate things together? Like how did I start the topic? Did you notice how did I start the topic with biochemistry? We took it to the level of physiology, we took it to the level of pathology, we took it to the level of pharmacology. So this is the entire crux of medical education. First of all, let us start with the biochemistry part of orthopedics. What is the structural and functional unit of kidney? I think it is nephron. What is the structural and functional unit of brain? I think that's neuron. What is the structural and functional unit of bone? I'm sure you all got it right. That is what is called as osteon. Now, friends, when we talk about osteon is actually when you see it is made up of two things. One is the organic part, another one is the inorganic part. ठीक? Now, as far as the inorganic part is concerned, this is essentially composed of what? Minerals. And I am sure that you all are aware that there are two essential minerals which are found in bone, which are basically calcium and phosphate. Do they exist freely inside the bone? Mhm. They always exist. They never exist independently. They never exist freely. They exist in a bound form, that is what is called as calcium hydroxyapatite. All right, just remember this. Now let's talk about the organic part. Organic part is further composed of two things. One is what is called as matrix, and the other one is what is called as cell. First, let's talk about matrix. Matrix is further composed of two things. One is called as protein, another one is called as proteoglycans. Bone has got two types of strength. One is called as the compressile strength, the other one is called as the tensile strength. Proteoglycans are basically responsible for compressile strength of the bone, and believe me, it is an MCQ. As far as proteins are concerned, they are further composed of three things. One is called as the CP, which is the collagenous protein. The other one is the NCP, which is the non-collagenous protein. And the third one that you have here is basically what is called as an enzyme. Now, first of all, when we talk about CP, collagenous protein, always remember that it is the most abundant collagen which is found in bone. That is what is called as type 1 collagen, again in MCQ. Now, this type 1 collagen is the actual reason behind the tensile strength of the bone. As far as non-collagenous proteins are concerned, you should remember the names of osteocalcin. You should remember the names of osteonectin. Some people even say that osteopontin is also very important. If you can remember it, that's good. If you can't, that's even better. Nobody will ever ask you. As far as enzymes is concerned, there is only one enzyme that we need to discuss here. That is what is called as alkaline phosphatase. I'm sure you got a bit of a hint of what I'm talking about. Now, when we talk about cells, guys, it is very simple that we are dealing with three different types of cells here. We are dealing with three different types of cells here. The first cell that we need to know is what is called as osteoblast. The second cell that we need to know here is what is called as osteocytes. The third category of cell that we all need to know here is what is called as osteoclast. First of all, let's talk about osteoblast. I have a very simple question for all of you. What does osteoblast do? It leads to formation of the bone. सबको यही पता है osteoblast bone बनाता है, but it doesn't happen in this way. Osteoblast gets the incorporation of collagenous protein, it gets the incorporation of non-collagenous protein, it gets the incorporation of alkaline phosphatase, everything which is mentioned on towards the extreme left of your screen, and osteoblast with the help of all these things make something which is what is called as an osteoid. Osteoid is a soft bone, immature bone, malleable bone, ductile bone, kamzor pilpuli haddi. Let's say, for example, there are some relatives at your home tonight. Your mom goes to all the kids and she asks everyone, what are you going to have tomorrow morning in the breakfast? Somebody says chapati, somebody says paratha, somebody says puri, somebody says whatever. So what she does is, whatever flour that you have, wheat, maize, whatever it is, she makes a dough in the night so that tomorrow morning it will be easy for her to cook anything for anybody. That dough is basically osteoid. It is that malleable, ductile, immature, uncalcified, unmineralized bone, which can become a long bone, flat bone, short bone, tubular bone, irregular bone, any bone. But does it contain strength? Mhm. It has to have strength. Yes. Where does strength come from? Mineral. What are the two minerals? The thing again, which I've mentioned just on the top of your screen in the middle part. So it gets calcium and phosphate, and when it gets calcium and phosphate, it gets converted to what? Come on, speak up, everyone. From where we started the topic. देखा आपने? After getting mineralization, what does it make? जहां से हमने इस टॉपिक का आगाज किया था, वहीं हमने इस टॉपिक को अंजाम दिया है. Those who understand Hindi will understand this. From where we began, we got that at the end. So this is how you integrate the basics of every subject. Anyhow, come to osteocytes. What are osteocytes? First of all, osteocytes are the resting, spent, mature osteoblast. What does that mean? खर्चे हुए cell. And it's an MCQ by the way. खर्चे हुए cell है. इसका क्या मतलब है? See, every cell has to go through a cell cycle. Every cell has to perform a job, and when the job is over, it gets retired. So osteocytes are nothing but retired osteoblast. They're done with their job, now they're resting. In fact, I would like to mention one more MCQ here, that they are the most abundant cells of the bone. In terms of quantity, they are the maximum. Now let's talk about osteoclast. Everybody knows that osteoblast leads to formation of bone, osteoclast leads to resorption of the bone. But I have a question for all of you. Are they good cell or bad cell? I have a question. Are they good cell or bad cell? Somebody is saying bad cell maybe. Somebody is thinking in his head bad cell. It's not a good cell. Why? Because it is leading to resorption of the bone. Always remember one thing. No cell is good or bad. It applies to human beings as well. No human being is good or bad. कोई इंसान अच्छा बुरा नहीं होता. हालात अच्छे बुरे होते. So osteoclast has got two functions to perform. Never say it's a bad cell. Why? I'll tell you why. It has two functions to perform. Both of them, by the way, start with alphabet R. R for resorption, R for remodeling. So, old age, it leads to resorption of the bone, it's a bad cell. But in our age, it leads to remodeling of the bone, that's a good cell action. Now, it belongs to monocyte macrophage cell lineage. This is important. Its relatives are, uncles are monocyte macrophage cell lineage. And they come from a family. I have told you the relatives, but let me tell you the family. They come from giant cell family. And that is why giant cell tumor is also called as osteoclastoma. Do remember that thing as well. Now, I want to take a minute here to talk about resorption. Let's see it's a bone, and let's see there is a multinuclear giant cell. What it can do to the bone, it can do resorption. When it will do resorption, you will see resorption pits, cavities. Those cavities were seen by a professor of histology called Isaac Howship, and when he saw those resorption pits under a microscope, he has given them his name. That is what is called as Howship's lacunae. All right, that is called as Howship's lacunae. Does that make any sense to all of us? So, my dear students, what you have right now on your screens is biochemistry. I told you in the beginning, I told you we'll discuss anatomy, physiology, biochemistry, pathology, pharmacology, We will not discuss orthopedics. We will discuss the basic subjects of orthopedics. Is this biochemistry clear to all of you? I hope it is. Now, let's move one step further. Now, when we move one step further, let's discuss physiology now. I'm sure that all of you have heard about this hormone here, that is what is called as calcitonin. And I'm sure that most of you know that calcitonin cuts serum calcium level. I mean, this is something which we all know by the virtue of our basic first year. Calcitonin cuts calcium in the blood, so decreases serum calcium in the blood. There is one more hormone. I'm sure you have heard of this hormone. That is what is called as PTH, parathormone, which contains basically 1 to 84 amino acids. What does parathormone do? Obviously, it will do just opposite of what calcitonin does. So it increases serum calcium level. I'm sure you all will agree. Now, I want to mention about a cell which, although I have just mentioned few minutes ago, osteoclast. Did I tell you that osteoclast can lead to resorption of the bone? Yes or no? Did I tell you that osteoclast can lead to resorption of the bone? Yes. I have a question for all of you. If osteoclast will lead to resorption of the bone, does that resorption further lead to increase in serum calcium level from the bone after getting resorbed? Yes or no? Yes. So, my dear students, I'm giving you two statements. My first statement, listen to my first statement. Parathormone increases serum calcium level, true or false? True. Osteoclast leads to resorption of the bone, and resorption of the bone further leads to increase in serum calcium level, true or false? True. Now listen to my third statement and tell me true or false. So can I say that in order to increase the serum calcium level, parathormone basically directly stimulates osteoclast to lead to resorption of the bone in order to increase the serum calcium level? Now tell me true or false? False. It looks true. It looks true, but it is not true. It looks true, but it is not true. Parathormone does not directly stimulate osteoclast. I can tell you why. Listen to this. Listen to this. Listen to this. What is the normal serum calcium level? 9 to 11. What happens when serum calcium level falls down? Everybody knows. When serum calcium level falls down, parathyroid gland releases parathormone and tells parathormone, which has 1 to 84 amino acid chain, that go and increase serum calcium level. What parathormone does? First of all, parathormone goes to GIT. Parathormone tells GIT that, hey, GIT, whatever calcium this person is having in the diet, GIT, I have a request. GIT is like, yes, tell me. GIT, whatever this person is having calcium in the diet in the form of milk or green leafy vegetable, I have a request that can you please increase the dietary absorption of that calcium from the food into the gut to increase the serum calcium level. GIT is like, listen, parathormone, you alone are not sufficient to stimulate me. You have to take somebody's help. PTH is like, tell me, whose help do you want me to take? GIT says, go and take the help of 125 dihydroxy cholecalciferol, that is vitamin D. PTS goes to vitamin D3. Vitamin D3 is like, fine, I'll help you. Let's go and stimulate GIT to increase the dietary absorption of calcium into the blood. But it happens, but believe me, it is not sufficient to restore the serum calcium level. Then PTH goes to kidney because PTH has to fulfill its job. PTH goes to kidney and tells kidney that, hey, kidney, I've been following you since first year of my MBBS. Each subject, everywhere, I find you. At kidney, I love you for the reason that you are a autonomous organ. You have autoregulation of GFR. Kidney, I know that you have three steps: glomerular filtration, tubular secretion, tubular reabsorption. Kidney, whatever you want to filter, please go ahead. Whatever you want to secrete in your tubules, please go ahead. But kidney, I just have a request that while tubular reabsorption, please I request with folded hands, please increase the tubular reabsorption of calcium so that from the urine it can come to the blood and my job is done. Kidney is like, of course, PTH, I can do it for you. But you know what? I'm an autonomous organ. I believe in give and take. You want calcium, you'll get it. But PTH, you have to give something in return. PTH, you have to give me your phosphate. So that phosphaturia happens. So that hypophosphatemia happens. So you want calcium, bro, you got it. But you have to give me phosphate. PTH is like, wow, what kind of relationship is this? I'm admiring you, I'm appreciating you, but you're doing business with me. PTH is like, PTH, kidney is like, it's business. Now, PTH has no choice except to go to Bone Industries Private Limited. We supply all sorts of calcium at the best prices. So, PTH reaches the factory of bone from outside the gate. PTH can see mountains of calcium over there. But PTH can't go inside. There's a watchman out there. Stops PTH. He's like, yes, tell me. PTH is like, I want that calcium which is inside the bone. I want to resorb the bone and I want to take that calcium out into the blood. The watchman tells PTH that you can't do that. PTH is like, no, no, I won't do that. You just let me go inside. I will go to Mr. Osteoclast. Osteoclast will lead to resorption of the bone and then we can take out this calcium. Watchman is like, sir, you can't go and directly meet Osteoclast. Osteoclast is a big man. He belongs to, come on, for the God's sake, he belongs to a giant cell family. He doesn't talk to stupid hormones like you, even though you have 84 amino acids. PTH is like, dude, but I need to meet Osteoclast. Then only we'll be able to resorb the bone. Watchman says, okay, I'll tell you a way. You go inside, but you don't meet osteoclast. You go and meet osteoblast. PTH is like, but watchman, what do I do after meeting osteoblast? I have to do resorption of the bone. I need to see osteoclast. He will do my job. Watchman is like, do whatever I'm telling you. Go and meet osteoblast. Okay? Okay. So PTH goes to osteoblast and tells, hello, Mr. Osteoblast, I'm PTH, 84 amino acid chain. Osteoblast is like, nice, nice. Nice meeting you, sir. Tell me, how can I help you? What would you like to have? Tea? Coffee? PTH is like, no, I want to have calcium. Blast is like, but how can I help you? I make bone. I don't resorb bone. PTH is like, he puts out his pistol, puts on the head of Osteoblast. He's like, listen, dude. Hey, Osteoblast, I know you make bone, but that's physiology. Now you're under my influence. That's pathology. You will eat the bone and you will tell Osteoclast to do it. Blast is like, but how do I go to my antagonistic cell? We are two opposite cell. I make bone, he eats bone. If I go and tell him to eat bone, what will happen to my reputation? PTH is like, but you have to do it. Blast is like, okay, fine. I'll send you a message, but I won't go directly. I'll give your message via a messenger. Since it belongs to somebody else, let's call it a secondary messenger. PTH is like, whatever. So Osteoblast calls a secondary messenger. Hey, Rankle, come here. Rankle comes to the scene. PTH is like, what is this funny name, Rankle? Rankle is like, Mr. PTH, I'm receptor for activated nuclear factor kappa ligand. PTH is like, okay, Rankle is fine. Blast is like, Rankle, go to clast. On the surface of clast, you will find a receptor. Go. Ligand, go. Make a ligand receptor complex. Ligand goes to receptor, makes a complex. Class listens to everything going on the surface. Class is like, hey, what is going on the terrace? Come inside. Oh, who are you? Oh, well, I'm rank ligand. Who has sent you? Osteoblast. Osteoblast? But why? He makes bone, I eat bone. Why does he want to convey a message to me? Sir, actually, he eats bone physiologically. Now it is pathology. He's under the influence of parathormones, sir. He has sent a message to you via me. Tell me what message? Sir, we want you to have resorption of the bone so that the serum calcium is increased. Class is like, fine, I'll do it. But listen, Rankle, before leaving, you have to reply to this MCQ. The receptors for parathormone are situated on osteoblast, osteoclast, osteocyte, all of the above. And the answer is receptors for PTH are situated on blast. Which is the secondary messenger involved in blast class pathway? Rankel. So, my dear students, did you understand that how I started with physiology? Did you see how I started with physiology and how I inculcated that physiology with pathology? That in physiology, this osteoblast was making bone. In physiology, osteoblast was making bone. But in pathology, under the influence of parathormone, oh my god, it is leading to resorption of the bone via Rankel pathway by stimulating clast. मेरा बात समझ में आया? So this is how you connect things. You connect biochemistry to physiology to pathology. Now I'll come to the last part, pharmacology. And listen to me very carefully now. When excess bone resorption happens, I have a question for all of you. When excess bone resorption happens, what disease does that lead to? That leads to this disease, that is what is called as osteoporosis. Everybody knows that leads to a disease called as osteoporosis. Now, I have a question for all of you. Is osteoporosis a common problem or a rare problem? It's a very common problem. Do we want to stop it? Yes, we want to stop it. Everybody wants to stop it. So, when you want to stop osteoporosis, now guys, please be attentive. Huh? When you really want to stop osteoporosis, you have two ways. Forget about two ways. You have one way. That one way is that you inhibit this rankle. Just think about it. If you really want to treat osteoporosis, see, osteoporosis will happen. कब होगा osteoporosis? Osteoporosis तब होगा when there will be too much of resorption by the osteoclast. So if I tell you a drug today, and that drug can inhibit rankel, don't you think that the message from osteoblast will not go to osteoclast and osteoclast will not lead to resorption and osteoporosis won't happen? So there is a fully human monoclonal antibody. Okay, I'm writing it here. So there is a fully human monoclonal antibody whose mechanism of action is basically nothing but inhibition of rank ligand. So this drug comes under the category of anti-resorptive to treat osteoporosis. Clear? I'll tell you one more drug now. Everybody knows that for any cell to do its job, it requires energy. For energy, you have to have ATP. ATP comes from first year MBBS, biochemistry, mitochondria, and some stupid cycle of some random pathway. So, if you inhibit the ATP supply for osteoclastic bone resorption, if you inhibit the ATP supply for osteoclastic activity, which is bone resorption, don't you think that you will again be inhibiting the resorption and you will be treating osteoporosis? Yes or no? Yes. By the way, this category of drug will be called as bisphosphonates. And believe me, they are the drug of choice of osteoporosis, whatever type, whatever age, whatever stage. Overall drug of choice is bisphosphonate. And again, these are anti-resorptive and there is no confusion about it at all. Clear? Now, in life, if you have to succeed, there are two options. A, you work hard. B, you don't let others work hard. So, when you don't let others work hard, that includes denosumab and bisphosphonate. What is osteoporosis? Excess resorption, less formation. Nahin, excess resorption, less formation. So you have prevented resorption by denosumab and bisphosphonate. The second thing that you can do is you can promote formation. How can you promote formation? Let me tell you. You can promote formation by giving a patient recombinant parathormone of 1 to 34 amino acid chain, which is given in intermittent pulse doses. Recombinant parathormone amino 1 to 34 amino acid chain in intermittent pulse doses and low pulse doses. How? You will give a pre-metered, pre-calculated, pre-desired dose of parathormone in such a way that dose will stimulate which cell? Come on, speak up. Which cell? See the cycle. You will give only that much amount of prefixed, pre-metered, pre-desired, pre-calculated dose that PTH will stimulate which cell? Osteoblast. And that's all about it. The effect of the dose is finished, the cell cycle is finished, everything is finished, and you will promote osteoblastic activity, and that will lead to formation of bone. So you will call this drug as osteopromotive. You will call this drug as osteopromotive. By the way, what is the name of this drug? A very famous MCQ. This is what is called as teriparatide. So we have concluded something today. That if you want to remember drugs for osteoporosis, you can put them under three modalities. Number one, anti-resorptives, osteopromotatives, and a combination therapy which is anti-resorptive plus osteopromotive. As far as anti-resorptives are concerned, let's talk about bisphosphonates, which is overall drug of choice. Let's talk about denosumab. Osteopromotive, let's talk about teriparatide. Can anybody tell me which is that drug which is acting as a dual therapy? Although we don't use it clinically, but that drug is what is called as strontium ranelate. It has found to be quite nephrotoxic. That's why most of the people don't use it. So this is a dual therapy. So basically, my purpose is to teach you all with the help of this video that how can we integrate things together. देखा आपने? How can we integrate things together? Like how did I start the topic? Did you notice how did I start the topic with biochemistry? We took it to the level of physiology. We took it to the level of pathology. We took it to the level of pharmacology. So this is the entire crux of medical education, that as a senior doctor, teacher, lecturer, organizer, my job is to organize my subject with the help of pre and paraclinical subjects for all of you, so that we can do a vertical integration from first year to final year. That is the entire purpose of the video. And I hope you people will utilize this to clear your basics. And not only that, you people will use this tool in your preparation, anybody whosoever is listening to me. So integration, be it horizontal, be it vertical. This is the actual game changer for anybody who's preparing for a competitive entrance exam. Okay, so I hope you people have understood what we were discussing and you have taken down the notes. And if there's anything, you can see the video again. It will be there on the YouTube channel as well. And if still anything, just feel free to reach out to me. I'm Dr. Tushar Mehta, orthopedic surgeon, faculty of orthopedics at DAMS. You can reach out to me on any social media platform. Absolutely not a problem. I'm there on almost every social media platform. Still, if there is anything, Instagram, Twitter, even there's a YouTube channel. And still, if there's anything that I can be of help in, you can WhatsApp your query to me on this number. So, I wish you guys all the best for the other sessions of YouTube of dams. And thank you so much. God bless. Bye bye.